Bismillah ar-Rahman ar-Rahim. Hello and welcome to my lecture series in Obstetrics and Gynecology, Dr. Azdihar Sahmi Hamoodi. Our lecture today is about Hyperemesis Gravidarum. This subject can you find in your book 10 Teachers, Chapter 6, Antenatal Obstetrics Complications, page 173. I will give you a short introduction about nausea, vomiting, and Hyperemesis Gravidarum. Nausea and vomiting in pregnancy are extremely common. 70 to 80% of women experience these symptoms early in their pregnancy, and approximately 35% of all pregnant patients are absent from work on at least one occasion through nausea and vomiting. Nausea and vomiting in pregnancy tends to be mild and self limited and is not associated with adverse pregnancy outcome. Hyperemesis gravidarum, however, is a severe, intractable form of nausea and vomiting that affect 0.3 to 2% of pregnancies. It causes imbalance of fluid and electrolytes, disturbs nutritional intake and metabolism, causes physical and psychological debilitation, and is associated with adverse pregnancy outcome, including an increased risk of preterm birth and low birth weight babies. The learning objectives that you are must to know in this lecture are the definition, pathophysiology, differential diagnosis, etiology, and the treatment of hyperemesis gravidarum. Objectives that you are nice to know are the complications of it. Here we have some definitions. Hyper means excessive, emesis means vomit, gravidarum means pregnancy. What is the morning sickness? It is the nausea felt by about 50% of pregnant women on getting up in the morning. So it is nausea in the morning. Emesis gravidarum, it is the actual vomiting. Here nausea, here vomiting. Also in the morning. These two conditions usually start between the 4th and 6th weeks of pregnancy, that's to say, start early in pregnancy. It reaches the peak around the end of first trimester. Disappears about 12, 16 weeks of pregnancy up to 20 weeks. And in some pregnancies, it continue the whole pregnancy. Hyperemesis gravidarum, the vomiting here is confined to the not only to the morning, but it is repeated throughout the day. That's to say, day and night. And it affects the general condition of the patient, cause fluid and electrolyte imbalance, nutritional deficiency, weight loss, and sometimes the patient need hospitalization. What is the etiology and pathophysiology of hyperemesis gravidarum? For most cases is unknown, but the most accepted theory is hormonal theory. That's to say, the high level of beta SCG stimulate the chemoreceptors that triggers the zone in the brain, including the vomiting center. There will be increase in TSH because of the biological similarity in the chemical compound between TSH and beta SCG that result to what's called gestational thyrotoxicosis. There will be excessive level of progesterone that lead to relaxation of the cardiac sphincter and gastric reflux. So why this theory is accepted, the most accepted one? Because high SCG occur in these situations: early pregnancy, vesicular mole, that's to say molar pregnancy, and in multiple pregnancy. Another factors, for example, allergy to corpus luteal hormones, decrease in gastric motility, and deficiency. For example, deficiency of adrenocortical hormones and or vitamin B deficiency, especially vitamin B6 and B1. Nervous and psychological factors. For example, the patient, she didn't plan to be pregnant. So when she became pregnant, she rejects this pregnancy. She don't want to be pregnant. She rejects this pregnancy, and this psychologically will affect her body, lead to increase chance of nausea and vomiting, or fear of pregnancy, especially in these young primary gravida patients. Fear of pregnancy, fear to being mother, fear of labor, and so on. Other causes like first pregnancy, multiple pregnancy, abnormal pregnancy, trophoblastic pregnancy, that's to say molar pregnancy, the female fetus, age of the mother, more than 30 years, maternal obesity and high BMI, smoking, those with previous history of hyperemesis gravidarum, or they have family history of hyperemesis gravidarum, history of eating disorder and infection, especially H. pylori, gastritis. Other pathology mean any disease in other systems in the body, for example, liver, kidney, heart, and brain. What are the pathological changes that may happen with hyperemesis gravidarum? For the liver, there will be risk for small fatty infiltration. For the kidney, fatty degeneration of the convoluted tubules. For the heart, there will be risk for small subendocardial and subpericardial hemorrhages because of aggressive vomiting. To the brain, congestion and petechial hemorrhage, that will, especially to the brainstem, that is resembling to what has happened in Wernicke's encephalopathy, with that affect the vision, blindness, and confusion and coma. For the eye changes, there will be optic neuritis, retinal hemorrhage, and to the peripheral nerves, there will be degeneration, and to the whole body, is signs of starvation. When we do lab investigations for the blood, there will be hypovolemia. That's to say, these patients have high HB because of hemoconcentration. There will be electrolyte disturbance, especially hyponatremia and hypokalemia, increased blood urea, hyperbilirubinemia because of liver damage and increased liver enzymes, and acidosis. This is lactic acidosis because of starvation, so metabolic acidosis. For urine, there will be oliguria, decreased amount of urine, and that's why increased specific gravity, decreased chloride because of excessive vomiting with sodium chloride from the stomach, albuminuria and ketonuria because of, as we said, because of starvation. This schedule shows you the differential diagnosis, summary to differential diagnosis of hyperemesis gravidarum, because you must know all these differential diagnoses to exclude hyperemesis gravidarum. Here, explanation to all these differential diagnoses that's found in the previous schedule. In GIT system, the differential diagnoses are gastroenteritis, simply just gastroenteritis, biliary tract disease, hepatitis, any type of hepatitis, intestinal obstruction, peptic ulcer disease, pancreatitis, and appendicitis. In genitourinary tract, pyelonephritis, simply urinary tract infection and complicated by pyelonephritis that cause nausea and vomiting in the patient. Uremia, degenerating uterine leiomyome, some pregnant as leiomyome or myome, which is a benign tumor in the uterus, and during pregnancy, this myome exposed to degeneration, that's to say ischemic changes, lead to abdominal pain, sometimes severe pain that lead to nausea and vomiting. So maybe these symptoms come from this uterine myome and not from hyperemesis. Torsion, especially when there is large ovarian cysts that lead to ovarian torsion, lead to nausea and vomiting. Kidney stones, drug toxicity or intolerance. Patient with metabolic disorders. For example, she has diabetes and uncontrolled diabetes that lead to complication with ketoacidosis, nausea, vomiting. So the complication of diabetes is the symptoms of the patient, not hyperemesis gravidarum. Porphyria, genetic disorder that lead to accumulation of toxic material porphyrin that lead to, in acute cases, acute porphyria lead to nausea and vomiting, abdominal pain. So you must think of it. Addison's disease also because of low levels of, it's an endocrine disorder, as you know, in medicine, because of low cortisone. So in crisis, there will be also abdominal pain, tiredness, nausea and vomiting. Hyperthyroidism. Neurological disorders, for example, tumor or pseudotumor, cerebri, migraine and headache, also sometimes when it's severe associated with nausea and vomiting. And then you will think in pregnancy-related conditions, which is the nausea and vomiting of pregnancy, hyperemesis gravidarum, or acute liver, rare case, which is acute fatty liver disease, which is the defect in the fetal, it's a fetal fatty problem with oxidation of fatty acids. Problem with oxidation of fatty acids in the liver lead to accumulation of these fatty acids and nausea and vomiting in the mother. How to diagnose hyperemesis gravidarum? Simply by history and examination as in any other medical problems. What are the symptoms of hyperemesis gravidarum? The patient cannot retain anything in her stomach. The vomiting occurs through the day and night, as we said, because this is a hyperemesis gravidarum, let's say aggressive and the worst type of nausea and vomiting in pregnancy, even without eating. And sometimes she vomits bile or blood. There will be ptylism, that's to say excessive saliva production, spitting, that's to say eject saliva forcibly from the mouth. There will be thirst, constipation, and oliguria, decreased urine output. The patient suffer from depression, anxiety, irritability. That's to say the patient is psychologically unstable because of these symptoms. There will be sleep disturbance. And finally, in worst cases, there will be manifestations of warnings encephalopathy. As we said, there will be drowsiness, eye problems, vision problems, and loss of consciousness, sometimes confusion and coma. The signs, there will be manifestations of starvations and dehydration. There will be loss of weight, sunken eyes, dryness, dry, inelastic skin. Vitally, the patient is unstable. So the pulse will be rapid, weak, blood pressure low. There will be slight rising in body temperature. What will you do? What are the investigations you should do when the patient come and complaining of this severe vomiting? You will do urine analysis. You will see the ketones and the specific gravity of the urine. You will take a blood sample. Serum electrolytes will be disturbed, especially hyponatremia and hypokalemia. CBC, liver function test, there will be affected liver enzymes. TSH, there will be high thyroxine and low TSH because of, as we said, hyperthyroidism. You will do urine culture after you do simple urine dipstick. Why? To exclude urinary tract infection, because sometimes urinary tract infection give the same symptoms like hyperemesis. That's to say vomiting. Hepatitis screening, hepatitis A, B, C, because sometimes it's confusing with hyperemesis gravidarum. You will do ophthalmoscopy to see the retinal changes. ECG, when you see that the potassium level is abnormal or low. You will do ultrasound examination, both obstetric and abdominal. Obstetric must do because you want to exclude multiple gestations, trophoblastic disease, that's to say trophoblastic molar pregnancy, and you will do abdominal ultrasound to evaluate the pancreas, liver, biliary tree, to confirm your diagnosis. In management, the principles of management of hyperemesis gravidarum is to control vomiting, to control the fluids of electrolyte imbalance, to correct the metabolic disturbance in the patient's body, and to prevent serious complications. So you will admit the patient to the hospital. You will inform her not to eat, so nothing by mouth, and for about 2 days, up to 48 hours. You will give her fluid replacement, first in a form of ringer solution, normal saline ringer solution, and then it will be 5% dextrose to give her glucose. These liters should be given by infusion over 2 to 3 hours, every 1 liter. Sometimes in severe cases you need to give her internal or what's called parenteral nutrition, that's to say nutrition IV. You will recommend her for dietary and lifestyle changes after you finish this 48 hours rehydration by separating solids and liquids when she eats food, by eating small frequent meals, not heavy separated meals, and bland foods, must be bland foods. Avoid fatty food and potatoes, chips, and fast meals. Avoid drinking of cold and sweet drinks. Eliminate pills of iron if she take iron, because sometimes iron irritate the stomach and cause nausea and vomiting. And recommend her for high protein food. What about the medical management? That's to say the medication, drugs. First, you can give her nutritional support with vitamins, especially vitamin B complex, vitamin B1, and vitamin B6. Vitamin B1 is the thiamine, vitamin B6, which is a pyridoxine, vitamin B12, and vitamin C. You can give her antiemetics. For example, navidoxine, which is meclizine, it's an antihistamine. Antihistamine substance, the effect of antihistamine is to reduce the effect of natural chemical histamine in the body. That will decrease the symptoms of nausea and vomiting. Promethazine, which is called Phenergan, it's also antihistamine. It's alternative to navidoxine. Metoclopramide, which is called Placil, it's an injection form. This will help with emptying of stomach in people with delayed stomach emptying and reflux. For example, pregnant patients or pregnant female. You can give also hydrocortisone and prednisolone, but this in special cases. Corticosteroids used only in severe cases. Nursing care. These patients need social and psychological support from the medical staff, and the nurse must do what's called hyperemesis progress chart. This chart include the follow-up of vomiting, the frequency of vomiting, the amount, the color, and content. Vital signs of the patient should be put in a chart. Fluid intake and output. The follow-up of urine analysis, the specific gravity, albumin, ketone bodies, chloride, pigments, and the improvements every day after fluid replacement. In this analysis, for blood, follow-up of urea electrolytes and liver function, eye examination, which done in the first day may be repeated to follow up the changes if changes found in retina of the eye. The clinical features of improvement, how you will assess this improvement. You will see that the vomiting will be subside. The patient will feel hunger. She is looking better, as you see in this picture. There will be disappearance of acetone and acetone smell from the mouth, and the vital signs will be correcting itself, and the urine output will be more. What are the complications of hyperemesis gravidarum? If hyperemesis gravidarum inadequately treated, so the complications will be dehydration, anemia, electrolyte imbalance, for example, hyponatremia. There will be renal failure and renal incompetent function, hypoglycemia, jaundice, malnutrition, risk for DVT because of hemoconcentration, and risk for pulmonary embolism for the same reason. Risk for severe complication, what's called Wernicke's encephalopathy, which is thiamine deficiency that lead to eye problem and consciousness problem, and in severe cases, coma. Vitamin K deficiency, this will lead to, because of liver damage, there will be risk for maternal coagulopathy and fetal intracranial hemorrhage. And psychologically, the patient will complain of depression and post-traumatic stress disorder. This picture shows you the severe complications of hyperemesis gravidarum. Mallory West tears. These are characterized by upper GIT bleeding, secondary to longitudinal mucosal lacerations at the gastroesophageal junction, or what's called gastric cardia. Here you see these tears with upper GIT bleeding. The other complications called Bohav's syndrome. This is characterized by upper gastrointestinal bleeding also, secondary to transmural perforation of the esophagus. You see, this is the esophagus here, and here the esophagus, and because of perforation to the esophagus, because of aggressive vomiting, there will be bleeding in it. And this is called Bohav syndrome. Well, with this slide, I will finish my lecture. I would like to thank you very much. Thank you very much for your attention. I wish you a good luck in your study. Goodbye.